Visual field screening. The visual field testing is a subjective test that can detect scotoma on your vision. A scotoma's size and shape can describe how the eye disease or a brain disorder is affecting your vision. There are two types for visual field test: the confrontation test and the Amsler Grid test. Who needs visual field screening? Loss of visual field is the earliest detectable sign in number of diseases affecting the eye and the CNS. Visual field testing is an important part of regular eye care for people who are at risk for vision loss. Those people who have glaucoma, multiple sclerosis, hyperthyroidism, pituitary gland disorders, CNS problems, stroke, diabetic, and high blood. Those are the people who needs visual field screening. Why? Because these people are those who are in risk of losing their visual field, and later on, it will become complete vision loss if it is not treated as early as possible.
Amsler Grid Test. The Amsler Grid is a square-shaped grid used to detect or monitor metamorphopsia or scotoma, involving the central visual field in various disorders of the macula and optic nerve head. So when we say metamorphopsia, it refers to distortion of images, while scotoma refer to blurred image or complete absence of image. The grid gets its name from Mark Amsler on 1891 to 1968. He is a Swiss ophthalmologist who described the chart in 1947. The chart's mounted on stiff cardboard in a ring binder. The Amsler Grid is a rapid, qualitative technique designed to test the central 10 degree of the visual field. Clinical significance. Amsler Grid is an important, simple tool to detect or monitor macular diseases. Advantages. It is inexpensive and portable. It provides quick and easy measurements and effective for confirming the presence of macular lesions. The disadvantages. Poor at detecting scotoma smaller than 6 degree, and it rely heavily on subjective interpretation and may also be compromised by the completion phenomena, which perceptually fills small gaps in line stimuli. Our Amsler Grid has 7 different charts. Each chart has an overall size of 10 cm vertically and horizontally, and each small square measures 5 mm in each direction, subtending approximately 1 degree at 30 cm. The patient is requested to describe lines that are missing or distorted. This is the chart number 1. This is the standard chart and usually used in Amsler Grid testing. It consists of white grid and a black background with central fixation point. It is used in every case and in many cases is sufficient. The chart 2 is similar to the first chart. The difference is that it has an addition of 2 diagonal lines extending from the fixation point. It is for use with patients having a central scotoma, and the patient is asked to look where the 2 lines would cross. The chart 3 is a red grid and black background for use when investigating scotomas for color. Chart 4 has white dots but no lines and a black background for use and is designed to detect scotomas only. Chart 5 has white parallel lines on a black background and it is oriented horizontally to detect metamorphopsia. Chart 6 has black parallel lines and a white background, also designed for detecting metamorphopsia. While Chart 7 is similar to Chart 1, but contains smaller squares in central 8 degrees. Purpose of Amsler Grid testing is to assess the integrity of the visual field corresponding to the macular region of the retina. The indications: an Amsler grid should be performed whenever macular disease is possible diagnosis. Example, when the patient best corrected visual acuity is reduced, and in patient with diabetes, high blood, and others. And when the patient has an acquired color vision anomaly, and when the macula has any unusual appearance. This is observed during ophthalmoscopy. If only one eye is affected, both eyes should nevertheless be tested. Some authorities include Amsler Grid testing among the routine entrance test, particularly for elderly patients or geriatric patients. Equipments used: Amsler Grid book or the Amsler Grid chart, occluder, and the source of illumination. Setup: the patient wears his best near correction and holds the occluder. The examiner holds chart number 1 at distance of 30 cm from the patient under bright illumination. Procedure: Number 1, have the patient occlude his left eye. Unless one eye sees much better than the other, in that case, test the better seeing eye first. So this means if patient eye has the same visual acuity, first is to check the right eye. But if patient has different VA, check first the better eye. This will enhance the patient's understanding and thus the reliability of his responses to the test. Number 2, say to the patient, look at the center white dot. Can you see it? Throughout this test, you must continue to look at the white dot while I ask you some questions about this drawing. If the patient cannot see the white dot, use chart number 2. Say to the patient, while continuing to look the white dot and without moving your eyes, can you see the 4 corners? Notice the lines. Are any of them missing pieces? Do any have holes in them? If so, where? Are all the lines straight? Are any wavy? And if so, where? Are all the little squares are same size? If some are larger or smaller, which ones? So these are the sample images that patient will see. Number 4, note the patient's response to each of the above questions. Throughout the test, watch the patient. Make sure that non-tested eye remains occluded and that the patient maintains fixation on the white dot. Throughout the test, maintain the testing distance at 30 cm. Repeat steps 2 through 5 with the other eye occluded. Recording. If there are no problems, record Amsler and the eye tested followed by W in L, which means within normal limits. Next, if there is problem, record the eye, the nature of the eye, and its location on the grid. Example, Amsler, OD within normal limits, OS, upper left corner not seen. If there are problems, attempt to draw that the patient sees, or have the patient draw that he sees on an Amsler recording chart. So example, Amsler, OD lines wavy centrally. OS, Potoma, 2 to 5 degree to left, 3 degree above, below fixation. And it is understood that plate number 1 was used, unless otherwise noted. If another plate was used, it just be specified. So this is the Amsler Grid recording chart. A blank form is shown for the left eye. So it means the left eye is within normal limits. For the right eye, chart shows positive findings. It means that the right eye has scotoma and metamorphopsia.
Confrontation test. A simple preliminary test on 120 peripheral vision. Confrontation test takes about 2 minutes to perform. If there is defects identified, it takes 5 to 10 minutes to define the extent of those defects and their relationship to key landmarks. The importance of the test. Clinical testing of the visual field is also critically important and for detecting optic neuropathies, for differentiating neuropathic from retinopathic disease, and for evaluating patients with unexplained visual loss. The purpose of this test is to screen for previously unnoted visual field defects. The technique is generally effective only for substantial field losses. There are advantages of the test. First, rapid screening. Second, additional instrumentation is not necessary. The disadvantages of this test is first, insensitive to subtle visual field loss. Poor patient comprehension or cooperation may limit usefulness. Third, poor inter-examiner reliability. This is the visual pathway. And visual pathway refers to the anatomical structures responsible for conversion of light energy into electrical action potentials that can be interpreted by the brain. It begins at the retina and terminates at the primary visual cortex. The equipment used for this test is first, overhead lamp, occluder, and fixation target. The setup for this examination. First, instruct the patient to remove his or her glasses. Second, the examiner faces the patient at eye level at a distance of 60 to 80 centimeters from the patient. The space between the patient and the examiner should be brightly illuminated, but the light should not shine directly into either the patient's or the examiner's eyes. Next, the rest of the testing room should be dimly illuminated. The procedure of this test. First, instruct the patient to occlude his eye. Second, tell your patient that you are going to show 1, 2, or 4 of your fingers in his side vision. Instruct the patient to tell you how many fingers you are holding up. Tell him keep looking at your left eye with his right all the times. Avoid holding up 3 fingers because this stimulus is too easily confused with 2 or 4 fingers. Third, close your right eye. Fourth, place your closed fist in the peripheral visual field. Your hand should be in the far periphery, but at a location where you will be able to distinguish the number of fingers exposed. Finger counting fields are actually a form of visual acuity of the peripheral visual field, so the fingers should not be moved or wiggled. In finger counting fields, the patient's visual field is compared to examiner's field, which is presumed to be full. Fifth, expose 1, 2, or 4 fingers, taking care that they are brightly illuminated, that the darkened exam room provides the background, that they are not pointing toward the patient, and that fingers are in the plane midway between you and the patient. Sixth, repeat step 5 in the appropriate 8 locations of the field on each side of the 4 visual field meridia. Seventh, when you have mapped the field for the right eye, have the patient occlude his right eye and repeat steps 4 through 6 on the patient's left eye. Eighth, throughout the test, monitor the patient's fixation and keep reminding him to maintain fixation on your open eye. Recording and interpretation. Record the results for each eye separately. Use FCF or finger counting fields to identify the procedure. If the field is normal, write full. If the field is abnormal, write restricted, followed by the location of the restriction.